There we are. Right. Okie dokie. We are going to kick things off because I am conscious that we are a couple of minutes late. So I will not waffle for too long, but I would just like to say a hugely warm welcome to everybody this evening. It is really lovely to be back in the world of glaucoma support groups after a short break for the summer. My name is Robyn Asprey, for anybody who doesn't know me, and I am the Development Manager for Southern England at Glaucoma UK. We always like to kick off a new season of glaucoma support groups by having a little bit of a look about what glaucoma is, and really, we would like this session this evening to be really interactive. We want you to be sending all your questions in so that Dr. Scott Mackie can answer them for us. So usually I say this little bit after the speaker has spoken, but I will point you straight away up to the Q&A section in Zoom so that you can start popping any questions in there. Just a quick reminder, obviously this is a virtual support group. Mr. Mackie doesn't have access to any of your notes or anything like that. So if they're very specific personal medical questions, we may not be able to do that today, but do always give our helpline a call or speak to your eye care professional. If you're joining us on Facebook, you can always pop a question in the comments, and my wonderful wingman today, Peter, will get those questions over to us. We always start our sessions with a quick poll. So I have just launched our poll now. If anybody is able to fill that in, that would be great. Just asking how much you already feel as though you know about glaucoma, so that we can see whether or not today has had an impact. So Dr. Scott Mackie is joining us today from Scotland. I will let him do the main introduction of himself, but we are delighted to have you with us today and to be talking all things glaucoma. I'm just going to give, or most people has replied to the poll, so I'm going to leave it up for 30 seconds longer, and then I'm going to stop talking and get out the way, and I am going to hand over to the real experts. Wonderful. Okie dokie. Just so people know, if you are joining us on Facebook, you're not able to join in the poll, but if you want to for future, feel free to hop onto Zoom where you will be able to do that. Okay, without further ado, I am going to hand over to Dr. Scott Mackie.
Well, first of all, good evening, everybody, and thank you so much for taking some time out. I'm a specialist glaucoma optometrist, 40 years qualified. I've been in every committee, General Optical Council. I'm working with Scottish Government about transformation of service in Scotland. So really, any questions you have at all regarding treatments, regarding new therapies, regarding side effects, anything, fire them in, and I will, as best, give the answer from a UK perspective, not just a Scottish perspective, but a UK perspective. So, Robyn, how do you want to start this?
I just wondered if you'd be able to start with kind of a quick overview of what glaucoma is, really. I have got a couple of questions that have been sent over in advance of this evening, but if we could have a quick overview, she says, as if there's such a thing, of what glaucoma is. If somebody's just been diagnosed with glaucoma and they're thinking, what does that mean? It would be, great if we could kind of have.
So glaucoma is a multifactorial disease. There's many types of glaucoma and there's many reasons for glaucoma. But ultimately, glaucoma is where you have usually a pressure associated in the eye, although not always, which causes a chronic disease where you get loss of visual function. As a thing called structure and functions. That means the back of the eye, the structure has been damaged, and the function, the damage then causes a functional problem, and that tends to reduce your side vision, and in the latter stages can also reduce your straight ahead vision. So there's this structure function correlation that we have, and when people hear about glaucoma, it can be quite a scary thing. It shouldn't be. They should have very good communication to patients to tell them, here's the plan, here's the action plan, what we're going to do. Because with a correct action plan, it should put people's mind at ease to what's actually going to be happening here. And there's great, including your own charity, there's so many bits of advice out there as well. So that's sort of glaucoma in a nutshell, if that helps.
That's great. And what I'm going to do, so we've had 3 questions come in live, and I've got other questions that I have had submitted beforehand, but I'm going to go through the live ones first, if that's okay. So one person has said, I find varifocals unhelpful. Are bifocals sometimes better with glaucoma? If people need kind of glasses to correct their vision, are there better or worse options for people?
Well, I mean, glaucoma and specifically varifocals or bifocals has no relevance really. It goes in the level of vision, and only if you had advanced glaucoma where your central vision was going down as well, then you may need extra power in the glasses. So when we get older, we need over 45, which I am, of course. These are single vision glasses, but you get varifocals which have no marks. The old bifocals are the ones with the lines on them. But there comes a point where you need extra magnification, and in varifocals, the maximum magnification you can get is a plus 3.5. So for people that need a 4, a 5, a 6, a 7 mag or a magnifier, varifocals won't work. But apart from that, if you've just got standard primary open angle glaucoma, whether you wear varifocals or bifocals is more a lifestyle choice. Varifocals are better for driving because you'll see the dashboard and you'll see if you stop your phone and you'll see straight ahead. If you have a bifocal, you'll see your phone, you'll see straight ahead, but the dashboard will be blurred. And of course, you only need to inform the DVLA if you have glaucoma in both eyes. And even then, if you do, the field test, the 120 by 40 field test for glaucoma is very difficult to fail. And if you do fail it, I would encourage anybody to appeal that, because the appeal rate is very high. So really, only in an extremely advanced glaucoma would you be refuted a driving license in the UK.
That's really helpful. In what you were saying there, you mentioned primary open angle glaucoma. One of the questions that I had that came into me before was, how do I know what type of glaucoma I have, and does it matter what type it is?
It depends on the does it matter? It depends on the person, because really, as a skilled clinician, as a consultant, you need to look at the patient and figure out, is this a patient that wants to know lots of stuff, or is this a patient that wants to know little? And that can be sometimes tricky, but sometimes you can overload people with too much information. But some people just want as much information as they can. So giving out leaflets, because really, once you mention the word glaucoma, everything else you mention in the first consultation, patients will forget because they'll be focused on that word glaucoma. So giving information away is a really good thing. Signposting them to resource services such as yourself is a good thing. But ultimately, whether it's primary open angle glaucoma, primary closed angle glaucoma, chronic open angle glaucoma, normal tension glaucoma, congenital glaucoma, secondary glaucoma, there's so many variations. But really what you want to know is, ultimately as a patient, am I going to go blind? I'm going to lose all my vision here, and what does this really mean? I think a skilled clinician would be able to explain, look, this is a chronic condition, here's how we're going to manage it with the therapies, and here's the sort of progression that we're looking for, and here's the timelines that we're going to be seeing you for, because that is a condition where you're given a ticket for life of either being managed at the hospital, or very much more nowadays trying to manage in primary care in optometry settings or virtual clinics.
That's great. Thank you. We've had one question come in that said, I've been treated for glaucoma for almost 20 years. I've just been seen by a different consultant who thinks that it isn't glaucoma and has arranged for me to have an MRI. What's happening?
Well, obviously, the caveat here is I haven't got any clinical notes, and I can't make a diagnosis on just little information. But what I can give you is some pointers. First of all, the more we learn about glaucoma, sometimes we see patients that we've been treating for years with glaucoma, and nowadays with modern imaging and investigation, we sometimes think, well, that's maybe not glaucoma, maybe it's never been glaucoma. And that could be, for example, you have a very thick cornea, and the measurement in the opticians have always been really, really high. But actually, we now know, because of thick cornea, it's actually not that high. It's actually within the okay limits. The particular case you talk about, if they're looking for an MRI scan, what they're looking for is there any other condition that's mimicking the glaucoma, right? So glaucoma tends to give you a side vision loss, field loss, called an arcuate loss, because it's like an arc. But there's other conditions that cause that loss. So what they're looking for there is there something else that's going on that would be different from glaucoma? And that's why they're doing imaging. But I wouldn't be too alerted by that, because or worried, because they're just looking at a differential diagnosis.
That's really helpful. Thank you. Another question, kind of talking about vision distance, actually. Somebody saying, can glaucoma vary to a person's vision distance on a day-to-day basis, i.e. on one day distance vision seems good, and yet on another day it seems not so good? Is that likely to be being caused by somebody's glaucoma, or is there any other explanation?
You can have pressure changes during the day. So pressure's higher in the morning. It's called a diurnal variation. It's higher in the morning, and it tends to then get less in the evening. And just like your blood pressure, when you sleep, when you're supine, it goes down. And that's why some medications we say take in the evening, some medications we say take during the day. The only thing that would affect vision fluctuation more so than glaucoma, but you get it along with glaucoma, is dry eye. So a lot of glaucoma medications unfortunately got preservatives in them. That's because when you open the bottle, you have to stop the bugs growing in the bottle. But preservatives by itself can give a chronic red dry eye. So some people with glaucoma have to take dry eye medication with it as well. And dry eye does fluctuate your vision throughout the day. As your eyes get dry, your vision gets poorer. The only other cause of visual fluctuation in glaucoma would be if somebody had a condition where the cornea, the front of the eye, was getting a little bit waterlogged, and that's called Fuchs dystrophy, which in combination with glaucoma just means that the front of the eye gets a little bit waterlogged as the pressure goes up a bit. As the pressure goes down a bit, it gets less waterlogged. But that latter scenario is less common. The most common one, which is, you should always go for the most common one, that's what I tell the juniors, is dry eye.
Fab. And what does dry eye affect all vision, or specifically kind of distance vision?
Well, dry eye affects it all vision, but the things that you tend to notice is the things that you're looking at. So if you're watching the TV and it's a wee bit blurred, you'll notice it. But it could also be reading and you notice it. And certainly things like the computer, if you're on the computer for a while, you should take breaks or use artificial tears, because it's really just wafting off hot air. And actually, when you stare at the computer, you blink half the time that you do when you're outside. That's why a lot of people say, when I'm outside, I don't understand about dry eye, but my eyes are wet. That's called a dry wet eye, because as you go outside, the wind stimulates you to blink and blink, and it tends to over produce tears. So that's why you can get a dry wet eye, and people don't understand it. They say, I've got dry eye, but my eyes are wet outside. Why is that, doctor? That's it.
Yeah. And the latter one that you mentioned, I can't remember the name you said, where you mentioned them kind of being almost a bit waterlogged at the front of the eye. Is that something that kind of somebody would be able to pick up? Would somebody with glaucoma kind of know that that's a thing that they struggle with, or?
Yeah, if you've got to remember that glaucoma, a bit like age, a bit like, I'm losing my hair. You get older, there's other things happen at the same time. So even though you've got glaucoma, another thing that happens in the corner of your eye, you have a little puncta which drains the tears away. As we get older, it tends to get narrower, and then that means it can overflow. And what you can do, if you go to an independent prescribing optometrist who does lacmo syringing, we do it at the hospital, but it's a simple technique to teach. Then you can flush through the glands, and that can give people a lot of relief. And we tend to do that in practice. I tend to do that maybe about 3 or 4 times a month.
Okay, interesting, fabulous, thank you. We've had another question come in live saying, I've had trabeculectomies done on both of my eyes and one doesn't feel the same as before. Can this be normal? I've had 2 bleb needlings done as well since. So kind of same operation, in theory, you know, you might expect that you're going to feel similar after both of them, but this hasn't been the case for this person. And kind of how normal is that?
That's very common, and especially needling, because what they're doing with the needling there is they're trying to increase the filtration through the bleb, because sometimes with scar tissue, but you can redo a bleb, but the needling is to allow filtration. It's very common that occurs. It's also very common if you have cataracts, for example, common again in old age. We tend to take cataracts out now sooner with people with glaucoma because it reduces the pressure 2 or 3 mils as well. So there's a big study called Eagle study that did that. But everybody will say, that's my good cataract doctor, that one wasn't so good. Nobody says they're both the same because they're unique operations, so they're always slightly different.
And that often, you know, is that to do with the process of the surgery itself? Is it to do with kind of just eyes healing differently? Kind of what, I guess it might be all of those things.
Well, you're absolutely bang on. It's a multiple of factors. I mean, if you've got some needling there, you've probably got some scar tissue that occurred in that eye. So did that eye previous have any uveitis, which is infection inside it, which can induce scar tissue? But they can be very different, especially cataracts, for example. You might put a lot of power in one cataract to take it out using the probe, and the probe in the other eye is less power, so you tend to get less complications with less probe power. But one cataracts are very unsymmetrical, so one's usually more prominent than the other when you do the op. And then the health service usually do one list for the other eye, depending on the waiting time. That could be quite some time. Privately, you tend to do them within about 6 weeks of each other. So can be a multitude of factors. But again, the caveat there is there any concerns about the caveat is always to say to patients, if you have a painful eye and it's red, that's a red flag. Go to your optometrist or phone your numbers in your glaucoma care plan, because a red sore eye is always to be looked at.
That's great. And in terms of healing after surgery, in terms of scarring particularly, if kind of generally the same procedure has been followed for each eye, would you expect there kind of be a similar level of scarring? You know, I know kind of often some people talk about how they're more prone to scarring or less prone to scarring. Like, would you expect if it was the same surgery done that the level of scarring would be similar?
Depends how well the trab works, because trabeculectomy is usually done with consultants.
Mm-hmm.
It's a more advanced technique to learn. But depending on the amount of bleeding when it occurs, depending on how much tissue you have there to use, again, pre-existing conditions as well. Are you reopening a trab that's been done before? So there's multiple factors to take into consideration.
Fabulous, thank you. We've had a question that says, can laser treatment result in scar tissue? We know that some laser treatments, especially in England, are being much more widely used now, particularly SLT. Is laser treatment likely to result in scar tissue?
Well, again, another pivotal study. They call these things called pivotal studies. It's just a big study that's been researched well and is shown to be very beneficial in outcomes. And it's called the LIGHT study, and that was a study for SLT. So SLT is effectively a trabeculectomy, and what that really means is all you think of is in the corner of your eye where the fluid is made and drained away. It's a bit like a sieve. And all you're doing with SLT is you're making the holes in the sieve bigger. So it's called a cold laser. So it actually doesn't cause any scarring. It opens the sieve holes more, so you get more outflow. So like with any treatment, what you're trying to do to lower pressure is your eye has to be at a pressure to survive, right? So average pressure around about, on most people, about 14 millimeters of mercury. So what happens with any treatment is either you're going to reduce the pressure by reducing the amount of fluid that's made, or you're going to increase the outflow, or you're going to do both, right? So some drugs work in one way, some drugs work in both ways, and you've got new drugs as well that are called neuroprotective drugs, which are specifically good for normal tension glaucoma, where your pressure is already quite low. So that's not the pressure causing the damage. What is that? And we think that's to do with the flow at the back of the eye. It's called ocular blood flow. How much fluid is flowing through that nerve at the back of the eye. And really, you have new drugs that are called neuroprotector drugs. So there's different ways that these work. But certainly SLT is not a scar tissue. But we do use other lasers. Remember, it's not the only laser we use. It should be the first line treatment now. So people shouldn't be getting given drops as a first line treatment. The idea is that they're given laser. But there's capacity issues, of course. Can everybody get that? Although we tend to use it as an adjunct therapy now in Scotland. So if people have medication but we want to just top it up a little bit more, we give SLT. But you've got other lasers that work in different ways that do cause scar tissue. You've got peripheral iridectomies, where we put 2 holes up under the lids to allow drainage. But that's mainly for people with a different type of glaucoma called angle closure glaucoma, which people really know about because they usually get halos and they get pain around the head and they come in because it's a symptom. Whereas the big problem with glaucoma is the vast majority of glaucoma is painless and symptomless, which is why it's so important to go to your optometrist at least every 2 years for a general checkup, and every year if you have a family member with glaucoma or you have glaucoma yourself.
Fabulous. Thank you ever so much. We've had a question that is asking, are there any glaucoma eye drops that may raise blood sugars? Any ideas on that?
No, I mean, blood sugar, my PhD was in diabetes. So blood sugar is mainly associated with blood sugar, you've got to watch because you can get a disease from your kidneys where your blood sugar level is increased, whereas diabetes, your blood urine level is increased. So it depends on the metabolism of your kidneys. So if your kidneys are working well, then and this is part of the general health questionnaire you would have before you look at medication, then you've got to watch that your kidney function is correct and your metabolism is correct before you start on any medication. That'd be a standard question. But there's no direct consequence to glaucoma medication and blood sugar.
Fabulous, thank you. Oh, here's a big question. We've been asked, what are the latest innovations or solutions to help detect and treat glaucoma?
Okay, so detection, the biggest revelation is, and quite a lot of your audience may know this, called a condition called OCT. So OCT is a machine called OCT. So a lot of high street optometrists, and certainly all the departments in glaucoma in the UK have an OCT. So you might have been to your optometrist and got a picture taken at the back of your eye, which is 2-dimension. An OCT is a 3-dimension plot. And what that does is it looks through the nerve, and what you're looking for is glaucoma hotspots. You're looking to add that information to, normally you do your visual field, so that checks your sight vision. We measure the pressure, sometimes with a puffer, but really not in the hospital, or specialist optometrists should measure it touching the eye. That can be a Goldman or a tonal pen. But OCT is this new toy where we're still learning, because we have a normative database in it. That means people that don't have glaucoma compared to people that do have glaucoma. And I just listened to a lecture actually today. CPD have to do hundreds of hours looking at new developments, and there's a new report called the Hood report, which we're looking at, which seems to be the best report for glaucoma right now. So it's just right off the shelf of being a new technique. So it's called the Hood report, and what it's doing is looking at your visual fields and comparing that to your OCT hotspot. And what you're trying to do is to see it as a relationship between the structure, looking at the back of the eye, and the function, the visual field in the OCT. So that's really new for investigation. For treatments, 2 lines of treatments that are looking new is ROCK inhibitors, which is a new type of medication. So we have standard medications. A lot of your audience may be on a prostaglandin, carbonic anhydrase inhibitor, a beta blocker, an alpha agonist, but we have this new thing called a ROC inhibitor, which seems very exciting. It's coming from the States. It's now FDA trials. We're also looking at new MIGS treatment, that's minimal invasive glaucoma surgery. So some of your audience might have heard of an eye stent. And that's where, if we're in doing a cataract, for example, we might put in a stent, a bit like you put in your heart. We put a stent in, and that again allows outflow. It's another outflow method. So these are the sort of newest techniques we're looking at this now.
That's great. Thank you. Right. I'm going to go to my pre-submitted questions. A question that comes up time and time again. If you've got glaucoma, how often should you have your eyes checked?
So it depends whether you're doing secondary care only, so you're in the hospital, so that'll be regulated by the hospital, or you're doing shared care, which is regulated by, say, a high street optometrist, or it could be a virtual department in the high street and the hospital. Or in Scotland, we have a new system called autonomous care, where, for example, people like myself just look after glaucoma patients in the high street. We do everything. But usually a good rule of thumb is that with any glaucoma, the maximum amount of time between visits should be a year, right? That's the target limits. Now, if you have treatment intervals before that, so it could be every 6 months, that's because we're maybe a little bit suspicious of something, we want to look at it. And if it's 3 months or a month, then there's more things happening quicker that we want to look at. So that's guided by your practitioner, but I would say a minimum every year. And then if you've been told sooner than that, please try to make your appointment. I know sometimes appointments are difficult to get to, but when the health service, the way it's working this now is, certainly in Scotland, 2 strikes and you're out. If you miss 2 appointments, you just don't get seen. So 1 year minimum.
Okie doke. And I would say if it's been longer than a year and you've not had an appointment through, please do get in touch with whoever your care provider is and see what is going on so that it doesn't get missed or dropped. We've had a question saying, does too much screen time exacerbate glaucoma symptoms? And if so, what can we do about it?
No. So basically, no. And there was a falsehood that blue light comes off screens and it causes all sorts of trauma to the eye. And there was a big study done. One of my colleagues in London is a professor and a specialist in lasers. And when I was working with the General Optical Council, we looked into this and we had to tell all providers, do not recommend blue screen glasses to any patients because there's no evidence base behind it. It must be evidence based, and screens do not cause any eye conditions at all. They cause, like anything, if you do anything for hours and hours, you'll get fatigue, but that's all. It doesn't do any pathological damage whatsoever, and certainly has no effect in glaucoma.
Wonderful. We have been asked, will my glaucoma affect my ability to wear contact lenses?
Only from the point of view that it can affect, cause of the comorbidity of the dry eye. Sometimes your eyes can be a little bit dry. They get drier with age. Women that are postmenopausal get more dry eye than men. Women tend to last longer than men. I think that's an even balance, on that one. Let's try to be fairness here. But contact lenses itself is not a contraindication if you have glaucoma. The only thing that you can't do is you can't put your glaucoma drops on top of the contact lenses. So you have to then, let's say you're in a plastic landing, you're taking it at night, we can take your lenses out when you do that. But it's only really the dry eyes. And remember, with contact lenses, you get daily disposables, fortnightly disposables, monthly disposables, yearly disposables. But you can put lenses in that are varifocals as well now, so you can see in distance and reading at the same time. Again, if you like any advice on that, I would encourage you to either look at the British Contact Lens Association, called the BCLA, find an accredited practitioner that knows what they're doing and can fit you with the very best contact lenses.
That's great. Thank you. Somebody has just come on to share their experience of, you mentioned earlier, driving and the DVLA, and I know it's something we get an awful lot of questions about. And they were saying that They did pass their first DVLA test. They were given a license for a year. The next time they didn't pass the test and got quite a frightening letter from the DVLA. Could have appealed, but it seemed very complicated and lost confidence. So yeah, I think just one of those things. If you are in the system with the DVLA, and I know you said earlier that if you don't get reissued a license to go through that appeal process, our helpline is always available as well. If kind of you've had that and you don't really know how to proceed, please do get in touch with us. I do know we speak to a lot of people. We do know how frightening and unsettling that whole experience can be.
Yeah, and I would add to that, Robyn, that the test is like, it's called an estimate test, right? And part of my PhD was looking at the old test, which was called a kinetic test. I did my PhD 30 years ago, but we did this kinetic test. That was the test for the DVLA at the time. We looked at the American estimate test, and it's a functional test. There's more spots at the bottom, which you don't use when you drive. But the DVLA thought it was a good test. I did it as part of my PhD. We compared the previous test to the estimate test, and that seemed a fit that meant that people had to get within the box 120 by 40 most points. So obviously, if you have a stroke and you lose both sides of your vision, both left or both right, you can't drive a car because you mount the curb. It can't be corrected with prisms. It's no use. But if you have glaucoma, only if you have really central loss right in the centre. So if you were looking at a pedestrian and you could not see the pedestrian, you can't pass, right? But if you have side vision loss, it's got to be very, very dense before you fail. Now, you can be panicky on the days, like white coat syndrome. I'll repeat the test again. You can go to an optometrist and ask for a private test. It does not need to be Specsavers. They have the contract for the DVLA because they wanted one provider. Because I used to do the DVLA test, as lots of my colleagues did. But you can go privately. You can use that as evidence, right? Make sure you've got your glasses on if that's the right glasses. Do it with the glasses on and the glasses off, because it could be the rim of the glasses that's causing an issue. Now, this is all for a standard driving license. Of course, if you have a vocational driving license, the limits have to be very strict. And if you fail one spot out of 120, you fail. But that's because you're driving an HGV or a bus. So that's very important. But I would encourage people to appeal. The appeal rate is incredibly high. That's been successful. So try not to be too disheartened. At the same time, if it's the right thing to pack it in, and that's a stake in the heart of independence, I get that. But do pack it in, because if you're told legally you can't drive, and you do drive, and there was a case in this in Scotland, person drove, knocked somebody down, worst decision they ever made in their life. It's a custodial sentence, but he regretted it, the person, all the time, because they didn't take the advice. So have to take the advice, and it's a very tough thing to say to patients. I would say that you cannot drive, but it's best for all concerned. But in saying that, if it's suspicious, get a second opinion and put in an appeal.
Thank you. A completely different topic now. Somebody has said, I have been diagnosed with glaucoma in one of my eyes. Am I going to have it in both?
No, not necessarily. There's plenty of patients who have glaucoma in one eye the rest of their life. You can have a condition where you've usually glaucoma in one eye and ocular hypertension in the other. And what does that mean? Ocular hypertension just means you've got a slightly higher pressure. So you think of a ladder, and the low pressure's at the bottom and a high pressure at the top. Generally, the NICE guidelines in England are over 24 is classed as glaucoma, as a rough guideline. But you can have a slightly higher pressure, say 23 in one eye, that's not glaucoma, because it's only the pressure that's high, and your field, your side vision, your OCT, all the other tests say no glaucoma. So only if it really goes above that, say maybe 27, 28, you might treat it as ocular hypertension. And that's where people get confused. They say, wait a minute, I'm taking a latanoprost in both eyes, but one eye's got glaucoma and one eye doesn't. How can that be? It's because there's been structural loss in one eye, but also functional loss, so structure function. The other eye, it's only structural, it's only the pressure that's the problem. So very common to have glaucoma in one eye, and ocular hypertension the other. But these terms, ocular hypertension, glaucoma, and I think that's fault as doctors. Sometimes we use these terms and we substitute them, and that shouldn't be the case because it confuses the patient, it confuses the GP, it confuses the juniors. So glaucoma is definitely structure function loss, ocular hypertension, structure only.
Great, thank you for clarifying. That's super helpful. We've had another question come in. Oh gosh, there's words in here that I don't understand, so I hope it means more to you than it does to me. I have epiretinal membrane causing wavy lines and blurry vision. Previously, I've had a PRESERFLO implant on that eye. So would an operation on the membrane possibly be a problem?
So an epiretinal membrane, all that means is the back of your eye, the retina, the bit that captures the light as it goes through and sends the image to the brain, it gets crinkly. So it's a bit like cling film, and it gets all crinkly, and that causes distortion. If you look at a line and you close the eye, you'll see in an Amsler chart, which is a chart with squares, it goes all wavy. Now you can go into the eye, a vitreoretinal surgeon. That's not a glaucoma surgeon; it's a VR surgeon who specialises in conditions at the back of the eye, a bit like a retinal detachment if the retina comes off. Same person, and we can peel off the crinkle and put it back on. But there are risks because you're going in the eye, like any surgery, and first of all, you're probably going to need a cataract operation at the same time because we go in the eye and it causes a secondary cataract. The other thing is you can make it worse. So what you can do is you can make the distorted vision worse, and you need to put in a prism after it. And the person, I've got a few patients that say, wish I never did it, right? I've got other patients that say, made a big difference. So then you've got to boil it down to anything. How much is this driving you bananas, right? You know, if this is really making you visually quality of life poor, then a risk benefit analysis is let's go for it. If however you can live with it, my advice should be live with it. Yeah, having the implant there does cause an issue of getting another problem. The one thing that we always worry about doing anything when you go in an eye, and this is cataract or anything that goes into the back of the eye, is you get a condition called endophthalmitis. That could be 1 in 3,000. Sometimes it goes down to 1 in 1,000. That doesn't seem a big number, but if you get this condition in the eye, that's it. The vision after that is very poor because it's an infection that gets in. Even though you've done all the infection control procedures, it just gets in that eye and it ravages it. So you've got to sign a consent form, and I would say think wisely because usually epiretinal membranes are just one eye. If they're both eyes, it's a bit like that question you said before. It's much more one eye than the other. So live with it. Sometimes you've got to patch the eye. Sometimes putting in a frosted lens is good for reading. So get a pair of reading glasses, go to your optometrist and ask for a frosted lens. A bit like, a car windscreen in a winter's day. Frost that lens down. That takes away all the distortion. Job done.
Fabulous. Thank you. Oh, I love these. I learn something every time. I have had one of our pre-submitted questions was, is there anything that I shouldn't be doing because of my glaucoma, e.g. swimming?
No, swimming. Actually, I go swimming a lot. I was swimming this morning in Arlington Baths, an old Victorian pool in Glasgow with a trapeze on top and everything. Very old-fashioned. But swimming is good for your cardiovascular health. Increasing your cardiovascular health is good for glaucoma because it acts as an antioxidant in the system. So having a good healthy living, trying to eat as best we can, having a couple of glasses of red wine because it's it's a neuroprotector, great. Whiskey on the other hand, maybe not so great, and alcohol in general, everything in moderation. But as for swimming, no problem at all.
Cool. Are there any other kind of lifestyle yes do or no don't do's for glaucoma?
Don't go bungee jumping.
Noted. I'll cross it off the list.
Don't go bungee jumping because the whole retina is everywhere. But remember, glaucoma is an age of the elderly. So I'm not trying to be ageist to say don't do the New Zealand first ever bungee jump. You can't do it because you're 90. But what I'm saying is it's not so good with glaucoma.
That's great, thank you. We've had somebody else ask, their eye drops were working to control their glaucoma, but now they're not. Why might that be?
It's a bit like antibiotic resistance. If you take something for so long, your body can then just get used to it. So the standard rule is you start off with a prostaglandin, that's first line treatment for medication. Then you move on to a beta blocker. So you might have a combined. Remember that it doesn't. We try to keep if we can, as many bottles down as much as possible. So you have a combined drop. So that could be one drop that does two purposes. And then you might add in a carbonic anhydrase inhibitor. So that's a third line treatment. So you're trying to control it three ways. But it is common that the drop stops working. The other thing that can happen is you get progression of the disease. So you need to treat it more thoroughly from the point of view that you have a thing called a target pressure. So what happens is when you first get glaucoma diagnosed, we try to reduce the pressure by approximately a quarter to a third. But if the disease is progressive, if you have more risk factors, you have a family history, there's lots of risk factors for glaucoma, apart from just family history. Having Reynolds with your hands is a risk factor, having migraines is a risk factor, having sleep apnea is a risk factor, being very short-sighted is a risk factor, being very long-sighted is a risk factor. So there's lots of risk factors. So the more risk factors you have, tend to be the more progressive it can become, which might mean we start you off with one drug, but then quite quickly we might say, well, look, we need to do two drugs, or we need to do SLT that we talked about earlier. And only after that, when you go through medication, SLT, cataract surgery, because that reduces it, maybe do MIGS, minor invasive glaucoma surgery, like the stent, moving on to a trab, moving on to a pump. That's the sort of hierarchy that you need to go through. So, but don't be overly concerned if we do change the drug, because the other thing is there's new drugs that are better. So prostaglandins are relatively new, and whereas we used to use a drug called pilocarpine, a miotic, when I first started 30 years ago. We don't use that at all anymore. So you do get innovation in drugs as well. So a couple of different diseases, a couple of different reasons here, sorry, but usually drug stops working, or progression, or both.
That's great. We've also been asked, will I pass my glaucoma on to my children?
Okay, so first degree relative. So if somebody comes in and they are 50 years of age, for example, the prevalence, what they call the prevalence, how much people have it in the community, is about 2%. Right, that's just anybody going to get it, it's 2%. Right. If you have a first degree relative, your mum, your dad, your brother, your sister, it can be, depending on the study you read, but it can be quadruple. Now, that's where you have to watch statistics, because I say to my patients, listen, okay, Robyn, we'll just do a scenario. Your mum's got it, glaucoma. Yep. That gives you a quadruple risk. However, let's just put that in perspective. It's a 2% risk because of your age, even though you're not 50. That goes up to 8%, right? Because it quadruples. That means you've got a 92% chance of not having glaucoma. You've got to be very specific with statistics. Because if I said to you, it's a quadruple risk, you're going, oh, that sounds terrible. If you say, well, actually, it's 8%. And also, if you are, it's a bit like if you are one of the 8%, well, let's catch it early, and let's treat it early. Let's get a management plan, and then we're sorted. It's the ones that come in that you worry about. The people who just buy ready readers over the internet, and then they go to their optician because they've got lots of sight vision loss. That's end stage glaucoma. That's a disaster.
Thank you. We've $1 million question come in here. Firstly, they say extremely helpful. Thank you so much. The next part is, why are there not enough glaucoma specialists in the UK?
Right. So I thought I was getting $1 million. Sorry, the $1 million question. It's a really good question, because look, there's the number of ophthalmologists per capita, so that's per member of the public in the UK, is the lowest in Europe, right? However, they are the most specialist in Europe. What that means is nearly every ophthalmologist in the UK is a surgeon, right? They do surgery. In Europe, 30-40% of ophthalmologists do what we do in Scotland as optometrists. They're really just, they are non-surgical and they manage conditions in the community. So the way forward is it's a disease of the elderly. We're all getting older. There's better detection. That means people who weren't diagnosed in the past are now diagnosed with it. And people are lasting longer because we're keeping people alive longer. So this is a bigger mountain. So what we need to do is, do we need to train more ophthalmologists? Yes, we do. The Royal College of Ophthalmologists has put that to the government, to the Health Minister. However, the other thing that we do need to do, and this is a quicker fix, and this is what has been happening, is train. Anybody can be trained as long as they have certain level of understanding, and then train better. So, for example, in Scotland, we've got a NESCAT qualification. This is brand new qualification, 300 hours of work, and it trains people like myself how to be really a community ophthalmologist, with all my other specialist training as well. So that means that everything that's stable in the hospital gets sent to me. So I'm getting downloaded 500 patients next month, and then I can look after them in the community much better for the patients, much better for the hospital, because then they're treating the more urgent ones. It reduces waiting times. So more and more shared care initiatives, virtual clinics as well. That's another big thing, where instead of taking up face-to-face appointments, virtually we'll be able to do that. And the other big thing that's going to come in is artificial intelligence. Absolutely looking at, we do it in diabetes just now, at the back of the eye. So artificial intelligence will be telling us about glaucoma progression better than humans, and that's really not that far away at all.
Wonderful. Right, this is going to be our last question, because I'm conscious we've got 5 minutes to go, but I think it is our last one anyway. So by some minor miracle, we've managed to pull this all in on time. Another person saying this has been great. They've said, I've had glaucoma for 35 years and I'm only 60. What's my long-term outlook? I know obviously you haven't got specifics, but kind of.
Well, if you're 60 and you've had it for 35 years, yeah, that means you were diagnosed at 25, right? So that means that you must have a special subset of glaucoma. So I'm assuming it might be uveitic glaucoma. It's a uveitis that causes glaucoma secondary. Then it means it's been picked up early. And what it does mean is you've probably been through lots of treatment programs. But we do have what we call progression analysis software, which you put in all the data of your visual field, your OCT, all of that, and it tells you a progression of where that patient should be heading. And that's really helpful nowadays, because then that can help you with better outcomes regarding whether you're going to do surgery earlier. I told you about cataract surgery. So you might be perfect candidate to get early cataract surgery, because you're going to get cataract anyway. If you have uveitis, I suspect you might have had the cataract surgery. But the outcome actually isn't, again, the caveat, because I don't know the case, but shouldn't be bleak, because really you've been looked after for a long time. You'll have lots of clinical notes here, lots of data, and then they've got an action plan to how to manage that in the future. So these are good questions to ask a consultant as well. What's the progression analysis? How do you put it into a progression indicator? Could you please tell me, am I going to be able to hold down my driving license for the rest of my driving life? And these are questions to ask. But I think hopefully you will be very well looked after.
Just on that, do all kind of everyone who is likely to be caring for people with glaucoma have access to that kind of progression indicator software?
It's software that we use in the hospital, and it's software that you can actually look up in Dr. Google. You've got to watch Dr. Google, but you can look up progression analysis, but you have to put in values that you would only get from the clinical tests. But there is another thing that we look at. We don't rely on it all the time, but it's a thing that we might look at to say treatment. And obviously, people who are earlier, younger, that is, earlier diagnosis, you tend to have treatment which is a little bit more robust, because what you really want to do is give them a visual quality of life. There's a big difference between somebody who's 90, and if you diagnose somebody with glaucoma at 90, you might diagnose it, but you might not actually treat it, because they're on other drugs, they're in a say, let's say they're in a care home, they've got a good quality of life. Do you really need to treat the glaucoma? No. So just because they have it doesn't mean you should treat stuff. You have to take everybody individually. But I wanted to say just at the last minute, Rom, is the people that said thank you very much and it was helpful. That's very nice to hear. That's what I do every day. That's why I love the job. But thanks very much for taking the time out to come and listen.
Absolutely. I'm just popping the second poll up for everybody who has joined. That the person who posted the question about kind of what things look like moving forward says that is reassuring. Thank you so much. I don't know if you've seen it, but somebody else posting to say this has been excellent. Thank you. I can't complain about my treatment, which has been first class, but nobody ever has time for questions, which hopefully was the whole purpose of this evening. And thank you ever so much for answering all the things that we've thrown at you, right from what is glaucoma to all kinds of more complex other eye conditions as well. So that has been really comprehensive. Thank you so much.
It was lovely, and nobody asked me about the alternative therapies like ginkgo biloba and bilberries, which is a sort of topical one just now, which is holistic and really doesn't really show there's been a big difference.
Wonderful. I am just going to flag before we log off the helpline details. If you have any other questions or queries at any point outside of our digital support groups, please do get in touch with the helpline. Their phone number is 01233 648170. They can be emailed helpline@glaucoma.uk. The email and phone are staffed from Monday to Friday, 9:30 until 5 o'clock. Do get in contact outside of those times if you want to or need to. You can always leave a voicemail or drop an email and they will get back to you when they are in. Our next webinar is on Wednesday, the 18th of October between 7 and 8 p.m. And it is people sharing their own experiences of using eye drops. We know that there can be challenges when it comes to eye drops, and we've got a panel of people with glaucoma who are coming to share their tips, tricks, experiences, and of course, answer all of your questions. I would like to say a huge thank you again to Dr. Scott Mackie for joining us this evening and giving up your time to join us. It has been a pleasure to share the evening with you, and I hope everybody has a wonderful week, and we shall see you all soon. Take care. Bye-bye.